Hello and good evening or good afternoon, depending on where you are joining from today on Tuesday. We're so pleased that you're here joining us for this patient forum focused on inherited breast cancers in men. I'd like to introduce my co-hosts tonight. We have Dr. Tua Pal, who's a genetics physician and the director of ICARE. Dr. Debbie Cragen, who is a genetic counselor and PhD at the University of South Florida, which is where I am as well. My name is Marlia. Welcome, Marlia Dean Cruzel. I'm a communication scientist and a BRCA2 previvor. And we are so thrilled that you have decided to join us to talk about inherited breast cancers in men. We've got a setup for you tonight. We're going to talk a little bit about ICARE first and give you some background information specific to men and breast cancer. And then we'll be transitioning to showing you some resources about men and inherited cancer risks, and then we will have our Q&A. So please, in terms of some housekeeping things, first and foremost, please note that this is a general information session, so please don't ask specific questions related to your specific medical situation. Number two, please though feel free to put questions in the chat. Or in the Q&A box. We will be monitoring that. Dr. Powell and Dr. Cragen and I will be monitoring that throughout our conversation this evening. So we will move over. Dr. Powell, I'll give it over to you so that you can talk a little bit about ICARE and set us up.
Okay, well, thank you, everyone. We're really excited to host this session, especially in recognition of Breast Cancer Awareness Month. We know that this is a super duper important topic that doesn't always get the attention it deserved. So just a few brief slides on our inherited cancer registry, which many of you may be familiar with, through which we provide education and resources and engage with both patients and providers. Many of you may already be participants in our registry. We've grown tremendously. I think we're close to 7,000 individuals at this point, and we have participants from across the country, and it really has enabled us to do many translational as well as healthcare delivery focused studies. So again, a big thank you to those who are already in ICARE, and we welcome those not already in ICARE to join if you're interested. These are some of the existing resources. We have provider and patient-focused resources, but then also these patient forums are something that we've started to do. The other thing many of you may also be aware of is that guidelines change pretty frequently. So through ICARE, we also send out targeted emails to ICARE participants as guidelines change, because again, we don't consider ourselves your healthcare provider, but we want to get the right information out to you as much as possible, because I know that in all of our clinical practices, it's hard to get information because it's moving so quickly. We also are very active on social media. These are some of the posts, but you can see, we have done several posts focused on male inherited breast cancers, as well as other topics. We do, for anyone who is interested in a general assessment that is gene focused, we still have our TIP study open, which is really looking at streamlining genetic education for inherited cancer. And this is for individuals both who have not yet been tested, as well as those that have been tested and want more information about their mutation. Now, just to get to the main meat of the conversation here, why are we here? So we know 1 in 10 cancers are hereditary in men and women, and that is key, right? It is also in men. It's not, hereditary breast cancer is just not a women's disease. And when we think about it, estimates are somewhere between 4 to 40% of male breast cancers are hereditary. The 40%, quite honestly, comes from the Icelandic study. So again, that's a founder mutation, but these numbers are substantial, so that anyone with any man with breast cancer should get genetic or should consider getting genetic testing. Genetic testing, of note, the whole purpose of doing it is that it can save lives through either early detection, cancer prevention, or sharing results with family members so they too can benefit from this information. And this is a common myth that only breast cancer history on mother's side matters. And that is absolutely not true. Breast cancer genes can be inherited either from the mother or the father. Now, the other thing that I wanted to highlight real quickly is when we're talking about genetic testing, genetic testing can mean a lot of things to a lot of people. And what we're talking about is testing for genes that you were born with, or germline testing in your constitutional DNA. So I have these figures here where on the left, you see these are mutations in every single cell of your body that you were born with, that was in the first cell that formed you, compared to, say, tumor testing, where it's a mix of your regular DNA, so the DNA you were born with, and the DNA that changed over time to form the tumor. So when we're talking about tumor testing is a mix of both your constitutional DNA as well as the tumor DNA. So when you get the tumor testing, that doesn't mean you have an inherited mutation. It could raise the chance, but it is not definitive, and more definitive testing is required to figure that out. Now, just a few things I wanted to highlight. Again, with it being Breast Cancer Awareness Month, there was a recent article that was published on CNN that, again, was aimed at increasing awareness about the importance of male breast cancer and heredity. And there was a piece that Beyonce's father, who himself is a BRCA2 carrier, talked in. So again, if anyone is interested, feel free to check this out. I'm now going to hand this over to Marlia to talk about some exciting resources that she's led the development of.
Thanks so much, Dr. Pell. I appreciate you setting this up and kind of giving us that background information. And as you'll see, we also put several of some links in the chat as well, so that you have easy access to those resources that Dr. Pell was talking about. But yes, so I'm excited to share one of the resources tonight is called Men's Stories About Hereditary Cancer. And this is a new resource for men about hereditary cancer. And specifically what my research team and I did, including Dr. Cragen on this call, is using interview data from real men's experiences about BRCA 1 and 2. This resource features 3 different stories. You see one example here, Timothy's story. And the first story is about deciding to undergo genetic testing and the genetic testing process. And then the second story looks at sharing BRCA genetic test results with children. And then the third story is about finding social support online. And the idea is to give men some modeling communication behaviors so that they can kind of see and get some specific resources for men related to hereditary cancer. So to view this or read this resource, you can use the tiny URL link that's listed on the slide. It was also just dropped in the chat. And please feel free to share this with any family members, men or women that you think this might be helpful as they contemplate either undergoing genetic testing or perhaps sharing genetic test results with family members. All right, so next we're going to move forward, and this is the main part of our patient forum tonight, and I am thrilled for our 3 featured panelists tonight. So I'm going to briefly introduce them, and then we will start the Q&A. So first off is Dr. Ben Park. He is a professor of medicine at Vanderbilt University and the director of precision oncology at Vanderbilt-Ingram Cancer Center. And then our second 2 panelists, Harvey Singer and Vicki Wolf, are the co-founders of His Breast Cancer Awareness. They are also brother and sister, BRCA2 carriers, and breast cancer survivors. And the organization's mission, I'm not going to steal your thunder because I know you're going to share all about it in just a second. But the main mission is to increase awareness and hence early detection for all men, and to help those who are at high risk due to genetics like BRCA and other risk factors to gain access to regular screenings. So we have a great lineup of medical expertise and knowledge. We have patient experiences. And so before we jump into our Q&A, as I mentioned, I'm going to turn it over to Vicki and Harvey and to share a little bit about his breast cancer awareness and some of the resources they have specifically for men.
Well, thank you. Thank you so much. And thank you for having us at this important and informative forum. I think it's a wonderful opportunity for so many to hear and understand a little bit more about men and breast cancer and, you know, the hereditary genetic mutations that go behind it. Our organization, His Breast Cancer Awareness, was co-founded back in 2009. In 2008, Harvey had been diagnosed with breast cancer. I had already had several bouts of breast cancer. I could guide him on what he could expect and some of the tests and procedures that would take place. But being a guy with a breast cancer diagnosis creates another whole level of stigma and the effects that go with that. So what we found when we were searching back in 2008, when he was diagnosed, was there was just no information out there about men or male breast cancer. And we just wanted to do something different about that. Between us, we have 5 sons, and we wanted, you know, that in itself to make a difference. But our mission for His Breast Cancer, as you mentioned, you know, we're here to help inform, to educate, and to provide support. Step 1 is education, because most people don't realize that men can even be diagnosed with breast cancer. You know, they only think of it as a woman's disease. They, as you alluded to earlier, they don't realize that men can carry a genetic mutation, that it can be passed down from a mother or a father. So for the first part, you know, a main concern for us is to educate, is to get that word out there, because earlier diagnosis is what's going to help save them, you know, save a life. For men, it's often diagnosed when it's much further progressed, and because of that, often more fatal. So we're here to educate, and then we're also here to support. You know, we've been through it. Harvey and I have been through it together, so we understand, you know, what a breast cancer diagnosis means, what a genetic mutation diagnosis means, and we provide that with in a number of ways. We also offer a private Facebook support group for men or their families, you know, to ask questions. It's a private setting, and just feel like it's a place they can go and not have that stigma around them. Everybody surrounding them understands. So that's what His Breast Cancer Awareness is about. And you know, we're happy that we can be here to help provide additional information for everybody.
So, Vicki, I just wanted to also, like you said, there is stigma to it, and destigmatizing it, because, you know, a cancer diagnosis is a cancer diagnosis, right? There shouldn't be the added stress of stigma. And when I had met with you and Harvey a few months ago, Harvey had mentioned this documentary that he was involved with. So I did want to bring attention to it, because again, you guys did all the heavy lifting to get it done. So it would be nice to bring awareness to it. So again, we can drop this information in the chat, but it's, again, pink and blue colors of hereditary cancer, which is, again, taking a look into the BRCA world, examining what it is and how this mutation puts both women and men. So the and men is the key part, at higher risk for developing numerous cancers. So
yes. We are, thank you for mentioning, we're very proud of Pink and Blue. We think that anybody who has the opportunity to view it, you will laugh, you will cry, and it really sends a great message. We are all about bringing blue into the world of pink, our logo, our branding, because breast cancer isn't just pink.
Yeah.
Absolutely. And that's a great transition to the next slide. I wanted to give you guys an opportunity as well to share a little bit about this resource. Harvey, did you want to talk a little bit very briefly about your book, Sir, You Have Breast Cancer?
Sure. And thank you guys for having us. Look, I'm the face of the stigma. I went through it. That's when Vicki and I realized that the world wasn't set up for guys going through the breast cancer world. The questionnaires, the mammograms, nothing was set up for that. When I was diagnosed, I had to go through surgery and then treatment. While I was in treatment, I had a lot of time on my hands. And I decided to write the story backwards from my life and how it progressed into the part where I picked up the phone one day after a biopsy and the call, the doctor on the other line said, "Mr. Singer," and I said, "Yes." She said, "Sir, you have breast cancer." And that was the start and the title of the book. But it's actually a more brevity type look at it. I didn't want to write a book about I had this test and I had that surgery and I went through this chemo treatment. I mean, I do talk about those things, but I wanted to bring some personality to it. So the book is more about my life growing up, where I was named after two men that died early in their 30s, and I always thought I was going to get cancer and die young. I didn't realize the genetic component. It was more superstitious at that point that my parents named me that way. But it turned out that it was the genetics that actually caused that, because there's this long line of cancer in our family. So the book was just there for me as an outlet, as a cathartic energy at night when I couldn't sleep, to write something about my life and something about being a man going through a woman's disease. And I'm proud to say that not so much the book, but Vicki and I have worked very hard for the last 14 years to change the face of male breast cancer and to bring some humanity to it, and some being that it's not just a woman's disease, and that guys get this and guys die from it, and they die more often by percentage because they're diagnosed later. And it's been our life's work now. It's turned into, we never expected it to turn into what it's been. We get contacted from men from all over the world that are going through it. And I had a call today with a friend, a coworker's husband, and I just helped walk him through some other stuff with prostate cancer, but we think it's genetically related. And it's just what we do. And they always thank you for it, but it's really, no, we love doing it and we love helping. So you can read the book. There's some things in there that probably shouldn't have written. My kids read it and said, "God, Dad, I didn't know you did that." But that just brought some realism, some humanity to the whole story. But thank you for having us, and we look forward to helping you in any way we can. And Dr. Powell, it was a pleasure meeting you, and we are so appreciative of your work.
Well, thank you. So going on, I'll just go through these slides. I think Vicki's kind of covered his breast cancer awareness activities, but again, they have this great website, and they also are active on social media. So please consider following them. We can drop those in the chat as well. And then there are some additional visuals and facts about when you conduct self-exam, how do you do it? And then again, highlighting 50% of the population carrying a BRCA gene mutation are men. I think we all tend to forget that, because the risks of cancer are, if we're going to think absolute risks, we think they're a little lower in men versus women, but that doesn't mean men can't carry it. So, and very important to consider. So I'll hand it over to Marlia. There was one thing that I wanted to ask Ben about, because I know Ben and I have also talked about how clinics are not set up for men, like screening clinics. And I can personally tell you that because of this, Dr. Park ends up seeing some of the male breast cancer patients directly in his clinic, so they don't have to necessarily go through the regular channels. But Dr. Park, do you want to comment on that? Because it's come up already.
Yeah, and thanks so much, Joa. First of all, thanks everyone for inviting me. This is always, I don't know, it's very cathartic and great fun for me to look at all the successes that we've had in terms of bringing awareness to male breast cancer. Harvey, I'm 99% certain we've met before because I'm pretty sure through my interactions with the then Male Breast Cancer Coalition, now Male Breast Cancer Happens, as well as the Global Alliance, that we've probably crossed paths before. So it's good to see you again. I think what you're saying is absolutely correct. And, you know, part of what I've learned talking with men with breast cancer is, you know, they get set up, not only is it kind of weird that they're wearing these kind of frilly pink robes, because that's what a lot of breast centers have and only have that, but also because they feel like they stick out like a sore thumb. They're in the waiting room and they are the only male that is not accompanying their spouse, but is actually in a gown or in a robe and a patient. And that presents, I think, a lot of psychological challenges that we don't often think about. So as Dr. Powell was saying, my clinic is actually outside now the breast center, and it's a general oncology clinic that we have here at Vanderbilt. And so I do see a lot of male breast cancer patients anyways, but now it's even more kind of pronounced because I think there's like that was said, a stigma of going to a breast center where it's pretty much just a preconceived notion that everyone is going to be a woman. So I think the more we talk about this and bring awareness, the more we can reshape what we think about breast cancer. And I love the fact, you know, now we're putting a little splash of blue on pink ribbons to remind us and continue to remind us that breast cancer happens in men as well.
Thanks so much, Dr. Park. I appreciate that and appreciate, you know, just even the physical moving of the clinic, right? To kind of address some of that stigma, particularly, I think, from a patient's perspective. Harvey, Vicki, I mean, do you have any additional comments there? I know we've kind of been talking about this idea of stigma, but you know, as the founders of this organization and from a patient's perspective, are there other things that we can be thinking of, either in clinics or perhaps things that we can be doing to help support and make men feel comfortable in these spaces?
Absolutely. First of all, I commend Dr. Park for having that available so that men don't have that stigma as much on them, and you know, there's another level of comfort. I remember, I'm going to speak for Harvey for a moment. I remember when he came out of one of his treatments and, you know, was visiting with one of the doctors, and he was there with his wife, and they met a friend, a neighbor, and the neighbor was, "Oh my gosh, Donna, I'm so sorry." And, you know, it just assumed automatically that Harvey was there for her instead of vice versa. So that's exactly it. I think that, you know, the most important as a patient for any situation is you have to be your own advocate. I think that's primary. You have to, you know, stand up for yourself, get educated, learn as much as you can learn. This is not, you know, it becomes an education. If you hear you know, a diagnosis with cancer, most people haven't looked before hearing those words and said, well, what if I ever, you know, I'm ever told that, what do I need to do? You know, all of a sudden it hits you in your face and you're overwhelmed and you've got, you know, you're emotional and where do you begin? So you know, you need to begin by getting educated. You need to educate yourself and find out as much information as you can. I think also, you know, talking with your family, finding out, you know, funny thing is family sometimes likes to push things under the rug, and, you know, if I don't talk about it, it doesn't really exist out there, but that's not, you know, not the case. And so you might be surprised when you start opening up the conversations, you find out your mother, your grandfather, an uncle, you know, a cousin was diagnosed with breast cancer, prostate cancer, early onset, or something else that, you know, just sets everything in motion for not only your diagnosis, but again, possibly the genetic testing, and opening that up. So I think that's, That's an important part. I think also talking about it will help reduce the stigma, you know,
Mhm.
sharing that information with others, women and men. I think it's important to realize that a lot of times the women behind the men are the push. And so, you know, don't just assume you got to talk to a guy, but talking to a wife or a sister or a girlfriend, they're going to have that conversation. They need to have that conversation, you know, with somebody close to them. And so that's an important direction to take. So
Men are notorious. Sorry, go ahead, Vic.
go ahead.
No, I was gonna say men are notorious for not wanting to go to the doctor. They think everything was a pulled muscle or something else is always an excuse. And Vicky was right. The women behind them sometimes have to push them. My experience when I went through it was that most of my guys couldn't believe it. My guy friends couldn't believe it. They were like, "Oh, you want to play from the red tees now? You're obviously a girl now." You know, they had some of that, and it was in jest, but it hit home. And I took it as a battle cry. And one of the reasons we started the foundation is like, I can't let the next guy go through this the way I went through it. And instead of being ashamed to go into a breast center, I prefer to go into a breast center because I wait for somebody to look at me and ask the question. I wait for the tech. A lot of the techs, the radiological techs that do my mammograms and my MRIs, they're shocked when they see me. And it opens up the world for me to open up their eyes. When I go in for any other kind of screening, the nurse inevitably that starts my IV looks at my record and she goes, "Wow, you had breast cancer? I didn't know guys could get breast cancer." So I use it as a battle cry. I used to like wear a shirt on the beach, and so I would hide my mastectomy scar. Now I wait for somebody to look at it just so I can engage them and maybe possibly save their life or save somebody they love's life. And for me, it's what I do. That's cathartic to me to see if I can help somebody. And every time we do help somebody and a guy comes back to us and says, "My God, you guys helped us so much get through this." That's all the reward we need. This is that we can help somebody get through. I'm sure as clinicians, that's what you do every day. But for us as normal people, we just love the fact that we can help somebody get through this. And if we can help them navigate the waters, we're not doctors. We can't tell them what Dr. Park can tell them. But we can kind of help them navigate and tell you where to go, what to do, who you should see, what you should research, and then make an educated decision. So that's part of it. But we're all in this together. And it's been, like I said, it's been 14 years of great reward for us to do it.
Well, and I think that's the beautiful thing, right? Like as we have, you know, patients and clinicians here on this patient forum, I mean, everybody is bringing expertise in their own way, right? And as a patient, when you hear, "Sir, you have breast cancer," you need both of that. You need the medical expertise, you need the context, you need the help with the treatment and the management or the prevention, but you also need that lived experience too. You want to know how to live outside of the clinical encounter and to move forward, right? And so I really appreciate both of those, answers to those questions. And you actually answered a couple other questions that have already been coming through in terms of how men in the family might get tested. And so we've, mentioned females in the family. There's been a couple questions, so I want to kind of go backwards a little bit, so to speak now. There's a couple questions about, what does the genetic testing process look like? How does it work? And so I thought that could be a point with which we could talk a little bit about first. So I don't know, Dr. Park or Dr. Powell, if you want to chime in terms of what does the genetic process look like from a clinician, and then Vicki and Harvey, you can jump in terms of, your experiences as patients, perhaps.
So I think you should start off.
Sorry, Marley, repeat what you want me to say.
Yes.
I was typing an answer. Sorry.
And I guess Dr. Cragen could answer it as well. But what does the genetic testing process look like? How does that work?
Okay, so what happens is when someone is identified to potentially be at higher risk, either because of a cancer diagnosis with a specific cancer type or at a diagnosis at a specific age, or even without a cancer diagnosis, if there's a family history of something that raises the risk of having an inherited predisposition to cancer, they should ideally come see a genetic counselor or sometimes an oncologist or their primary care doctor. Again, the main thing is getting the right information. So again, if you're not familiar with it at all, going to see a genetic counselor is a good first step. Now, once you see the genetic counselor, they'll assess your risks. They'll take a 3-generation pedigree. They'll look at other risk factors to kind of give you a risk assessment about, okay, what are the genes that are important to test and how high are the risks for you to be, to come back positive kind of thing. And what you want to make sure of is when you get the genetic testing, all genetic testing is not equal. So you want to make sure that the genes that need to be covered are actually included, because it's come to the point, right? We used to do genetic testing where we did one gene at a time. And each gene costs thousands of dollars, right? Whereas now we can do multiple genes all at the same time and cover many different conditions. But the thing is, when you do this, and if you miss a gene that you wanted to test for, insurance may not pay again to get another test to fix that. So that's why you want to make sure on the front end that the genes that should be covered actually are covered. This testing can be done. So it's testing on your germline or constitutional DNA. So the DNA that you were born with, which generally we do either through a saliva sample or a blood sample. There are some advantages with blood, but they're really minor. So saliva is just, just fine if it's more convenient. So, I mean, in a nutshell, and then once the results come back, the counselor or the physician will talk you through what are the next steps. Because to me, once you do the genetic testing, if you don't get the right information and if you don't act on it, then the genetic testing is useless, right? Like if you don't, like it has to impact medical management either for the individual or their family member. So it's super duper important to get the correct information. And by the correct information, I would also argue you want to get the right treatment. You don't want to get more treatment than you need. You don't want to get less treatment than what you need, because there are situations where sometimes you're advised to get a lot more than we would really advise based on national guidelines, versus the flip side as well. So
that's great. Yeah, thank you so much for walking us through that. And I wanted to highlight too, Dr. Cragen had put in the chat as well. If you're looking, or you want to explore genetic counseling or find a genetic counselor, there's a link there for find a genetic counselor in your area. But I want to give Vicki and Harvey opportunity, from again your experiences, any things about the genetic testing process. What might you tell somebody? A man who is interested in genetic testing or considering it?
So I'll go first here, Harv, if that's okay, because I had testing first.
You always go first. Yeah, you're one of the first people to ever get genetically tested. You go way back in the process, so go for it.
Yeah, so I had 2 diagnoses of DCIS and then a 3rd diagnosis of invasive cancer. And that was back in 2005, 2006. And all the times just lumpectomy, but we were discussing whether or not I had done an oncotype test and whether or not I should have chemotherapy with that diagnosis. And sitting in the oncologist's office, there was a pamphlet. That was the first time I had seen or heard, which, back then was about the start of, BRCA testing. And I just thought, I knew I had 3 sons, so I at first didn't fully understand what it would mean for them. I just knew that at some point, I wanted to better understand why I was having so many diagnoses of breast cancer. First of all, I'm pretty health-minded, slim weight, exercise, make healthy, lifestyle choices. Why am I getting breast cancer? Now we have our mother, who was in her 70s, diagnosed with breast cancer. She had a sister that when she was in her 70s was diagnosed with breast cancer. But I started at 37 and 39, and now I'm 48. And I just thought, I want to know more about this. If not for me, I really wasn't even thinking about myself and what it meant for me. I thought for my children, my grandchildren, maybe one day. Back then, I even thought maybe one day there'll be a vaccine, which we are getting closer to, that we'll just give them information that will help them. And that's why I chose to be tested in the beginning. When I found out, of course, I went through genetic testing and I was told that if I'm a carrier, here's what's going to happen. It's very black and white, where some cancer diagnosis, you fall into a little grayer area of how to treat, what your treatments might consist of. If you have a genetic mutation, it becomes a little more solidified. And I knew then I would have to have a hysterectomy because I would be higher risk for ovarian cancer. So I was all in and, found out I carry the BRCA2, BRCA2 mutation. And I shared that, with Harvey. I have two brothers. I told both of them and, they kind of heard me, but they thought breast cancer. What does that really mean to me? And that's sort of where it was left. A year and a half later, Harvey learned otherwise. And so I'll let you pick up on your genetic testing. But, for me, I do have three sons, an older son and a set of identical twin boys. My older son got tested. He did not carry the mutation. My twins, it was very important to me to have them test together. They're, because they are identical. I didn't want them to get information from the other one. I wanted them to go through the counseling, fully understand it, even though they know what I do and what we preach. I wanted them to hear it from the professionals and, not their mom. So unfortunately, my twin boys do carry the genetic mutation and, they do already have started their family, but, around 35 years of age is, common for them to be tested or when you're ready to start a family. And because of the knowledge that they now have, they are undergoing yearly mammograms. They will have, they already have a baseline PSA for prostate, and they will be earlier for colonoscopies and other testing at this point because pancreatic cancer is also in our family. So
Found
Well,
out
thank you
most
go
recently.
ahead.
No, go ahead. I was going to say that we're three children, and it comes from our mother's side, and all three of us do carry. And we have an older brother who Dr. Powell, when we met the first time, we were talking about it because he was just trying to figure out what was going on. And unfortunately, he was diagnosed with pancreatic cancer. He is in treatment currently. He actually had infusion today. While we were doing this, he sent me a text and his blood work. He's actually doing extremely well considering because it was near the bile, but it's just the odds. We know the odds are 50-50 if one parent is donating the mutation. In our case, all three of us got it. I have two boys. One couldn't get tested fast enough. One took forever to get tested. Fortunately, both of them were negative. And my older one, who's a very smart guy, finally got tested. I said to him, see, you could have known you were negative 11 years ago because he was worried he was going to get a positive diagnosis of the test and, have to live with the fear of it. He said, I just want to live my life. And I think this is a common theme throughout people that go through genetic testing. They don't want to know. They want to bury their head in the sand and say, it's not going to happen to me. And I don't want to know. And I don't want to live with that fear. But we all know here, living with it is knowledge. And Vicki's twins, my nephews, are living proof of it. I mean, they do everything the right way now. They know what to screen for, just like we know what to screen for. People ask me all the time, why do you screen so much? I do annual EUSs. And I said, I know what my risks are. I've had prostate cancer. I've had breast cancer. The other stuff is hiding somewhere there. So, I go to the dermatologist twice a year for melanoma checks. I just, it's a lot, but I get it. I'd rather find it earlier rather than later. The person I was talking to today who was diagnosed with a metastasized prostate cancer, I said, have you been genetically tested? I don't know this gentleman that well. And he said, no. I said, is there any other cancer in your family? He goes, my brother was diagnosed with prostate cancer at 51. I said, at 51, so you're 60, you have two early onsets. I mean, the likelihood that this was, and he's an Ashkenazi Jewish individual. I said, the likelihood is that you're carrying a mutation, so get tested, but the doctor didn't recommend it to me. And that's part of our problem in the system, is why aren't doctors recommending this, especially when they're not reaching out to know their family history. That's why Vicki and I preach, know your family history, understand it. God, Dr. Parker, sorry.
No, I was like, you hit a chord or something that resonates with all of us, and Tua knows this. And the answer to your question is, we are still not trained as medical professionals really in genetics, other than Dr. Powell, who is the geneticist. But even in my world of cancer, believe it or not, it's not really part of our curriculum. We're getting better because we now have more awareness of this. But you're absolutely right, Harvey. It is astonishing how many people don't understand that they should get tested. All metastatic prostate cancer patients should get tested, even regardless of age or family history at this point. And it all plays into what you're saying, is we got to increase awareness. Dr. Powell and I are pretty excited because we just recruited someone from University of Washington who's coming here. And part of his kind of research mission and shtick is to do the family testing. And he's got data that shows if you have people who are going to spend the time to talk to patients who have the mutation and then talk to their families, you can really get a faster uptick in people getting what we call cascade testing. And I'm super excited about that. But this is something that really strikes a chord with me, because you're absolutely right that people just put their head in the sand. Their doctors don't know. There's a million reasons and opportunities that we could do better.
Yeah, so I hear the common thread, on both sides is, that the education, right? The empowerment, right? In terms of knowing from the patient side, but also from the clinician side too. And I want to go back to, because as Vicki and Harvey were talking about, your children, one of the couple questions we've had, and so I wanted to spend some time on that. So Dr. Park, maybe this question could be for you. Some of the participants have asked about guidelines specifically related to, for example, BRCA carriers, or maybe Dr. Pell, you can answer this as well. But at what age should a man who is BRCA positive, when should they start screening? What does that look like in terms of, breast cancer, prostate cancer, these other different types of cancers related?
I'm going to turf that to Dr. Powell, because that really is her area of expertise. So too, it's what age should men get screened if they're like a BRCA carrier for these different cancers?
Yeah, so we say around the mid-30s, starting the breast exams. Again, even in women, we don't know that they work, right? So, but it is something that we in general will recommend. And then my recollection of the mammograms, I think it's starting, I'll have to check NCCN, but I think it's 40. Is that right, Ben? Annual.
Yep.
Annual mammograms. And we were very specific. Well, we were subtle in NCCN, but this is more important for BRCA2. So just to give you an idea of the risks, for BRCA2, the risks are 6 to 8%-ish lifetime risk for male breast cancer, which again is way lower than the 60 to 70% we see in women. But 6 to 8% is really, really, really high, right? Because the disease is so uncommon in men. It's way less than 1%. So if we're going to look at the relative risk, it's way higher in men. So that would be BRCA2, but you can also consider it for BRCA1 as well as PALB2. PALB2 and BRCA1 are kind of in the same range in terms of male breast cancer risk. BRCA2 being the most important. Same goes for prostate cancer. We say age 40, really with a PSA level plus or minus digital rectal exam. What I've been hearing from our urologists is the digital rectal exam can be off-putting for some men, and the urologist may not even need that. So the PSA may be actually sufficient to do the screening. And the reason to do the screening in men is most men with BRCA2, if they develop prostate cancer, it will be an aggressive form of prostate cancer, which is not normal, right? In the regular population, it is generally a disease of older age in men, and the prostate disease that men develop tend to be non-aggressive. BRCA2 is different. There tends to be a predisposition to aggressive prostate cancer, so you need to stay ahead of the curve. BRCA1, we're not sure about yet. Like, there's data that can go either way. Some data has shown maybe it's more aggressive, others have shown maybe not. So we don't know, but we still do say consider prostate screening in BRCA1. PALB2 is an evolving area for prostate cancer as well, which again, we don't know at this point.
Thank you so much. That's very helpful. And I think perhaps one more question in terms of cancer risks that came in. It's going out a little bit farther, but one of our attendees asks if there is any tools for calculating breast cancer risk in men. I don't know, Dr. Park, Dr. Powell, are you aware of anything that might be helpful?
You know, the issue has been that male breast cancer is still relatively rare. And so getting large enough cohorts to really dig into that data or develop that data really is just not there yet. We are, as a field, trying to, and have successfully in some cases, brought together institutions both nationally and internationally to see if we can actually take at each institution and each site their collection of male breast cancer data and pull it together. And this also includes pathology tissues. This was an effort led by Dr. Sharon Giordano at MD Anderson a number of years ago. And retrospectively, we could do that. And so there's still ongoing efforts to do that. So we can try to get these data and form independent guidelines in terms of male breast cancer versus female breast cancer. Before I forget, I also just wanted to interject the point. The other thing that I often see healthcare providers, my own colleagues, et cetera, if we see a family that has a lot of breasts or other types of cancers and they get genetic testing appropriately and it's negative, which it often is, I sometimes see the mistake being made saying, oh, well, you're good. Don't worry about it. And that is not the right answer. Right? I tell everyone we have 20-some thousand genes in our bodies. We only test for the most common ones we know of, which is at most maybe 70 to 80, 90 maybe. And think about it, it's a small fraction that we're actually querying for right now. So family history really trumps negative genetics. And really that can't be emphasized enough, but I hear it so many times. I just heard it the other day that someone said, oh yeah, they told me since I was negative. And this woman had this huge family history that we're all good. I thought, wow, that's really alarming.
Thank you so much for sharing that. Vicki, I see you nodding. I don't know if there was something you wanted to add there. I'll give you the opportunity if so.
Thank you. Well, I agree wholeheartedly, Dr. Park, and we hear that quite often, unfortunately, and we do talk about and we do stress just, familia. I mean, it's it's probably a mutation that hasn't been discovered yet, but your risks are still, increased. And so very important. And something that we talk about for men especially is to do, to learn how to do a self-breast exam. So they may not be followed and they may not be able to receive mammograms and, things, testing that way. So it's important for them to learn how to do that themselves so that they can notice quickly any changes. And that's something we have that information on our website, how to perform a self-breast exam with an image of a man,
Yeah. I noticed that on the website.
So, and it can be done, and if your girlfriend and you, or if she wants to help you and teach you or lay in bed and make it part of some, some close time together, then that's a bonus, But yeah, very important, to be aware of your own body and of course, any changes in any, at any physical concept, but especially, with your breasts, knowing some of the symptoms, knowing if there's some dimpling, some inversion of the nipples, some leakage, in addition to a lump or bump.
Excellent. That's really,
Marlia,
go ahead, Dr. Powell.
Yeah, the other thing I just wanted to bring up, so, in the chat, I've been monitoring the chat, and there was a comment about detection of multiple cancers with a single test. And I don't know if this is getting at multi-cancer early detection tests, but Dr. Park is actually an international expert in this arena. So Ben, I thought you could say a few words because again, it's being rolled out as
Yeah.
a test, even though it's not ready. So maybe you could just kind of give your regular spiel that you always educate
Yeah,
us.
you know, I think the hard part about this, I am one of the earliest developers of what we now know as circulating tumor DNA. And really what that is, just to put it in context, we've known for ages that all of our cells in our body actually secrete naked, free-floating, cell-free DNA is what we call it. And so if you have cancer cells in your body, they will also do this. But relatively speaking, the amount of cancer DNA to normal DNA is very, very little. It's like the proverbial needles in the haystack. And so there are different ways to detect this now. And this is something that we're using as a field all the time, mostly in metastatic disease, but now we're moving into earlier stage diseases. So in the curative paradigm, and we're even moving now into the primary screening. So you can imagine the first maybe families that you would want to do this are on higher risk. And there's a study in Canada that's actually going on right now to do this. There is one company called Gallery, and they have a test called Gallery, I don't remember. At any rate, it's come under some controversy, and they basically started selling it. Didn't have much validation, if any. Wasn't covered by insurance. They were charging money, and they were getting real world data to try to figure this out. And they've published on it. It's not very good. They're going through some troubled times. It's in the cancer letters. I don't know if you saw it this week too. I'll send it to you. So my fear is, and the technology, to be quite frank, is not something that would be state of the art anymore. And my fear is, and I've seen this already happening, that this has sent a negative message that these types of tests will never work. I think it's actually scared off a lot of companies from developing and going down this path. But I still believe that someday, and we're almost there right now for early breast cancer, that this will be an option that can help us in higher risk patients. I don't think the initial stage it'll be for everyone, kind of what they were doing, but I do think, you know, looking at Harvey and Vicki, is like, how great would that be that instead of having to get all these scans and scopes, et cetera, that you could get a tube of blood drawn, and it might even be able to point you, if you have cancer, where it's at. Because there are actual marks, that we call them, on the DNA of cancer cells that seem to be more or less related to the tissue of origin. So looking at those marks can tell you, oh, this is more likely to be a breast cancer or a colon cancer or pancreatic cancer. That's really kind of still science fiction, but we're headed there. And I think that that's one of the things I'm really excited about, that we may be able to use this to augment tests, not to replace them, but to help guide decision making in terms of what would be the likelihood that you have this cancer and how do we actually attack that.
Thank you so much for sharing that. That is great. Dr. Pell, yeah, go ahead.
Yeah, no, I just wanted to correct myself. It's actually mammograms for men start at age 50, not age 40. It would be age 50 or 10 years prior to the earliest diagnosis. So you could start it before 50, but you don't necessarily need to. There's another question in the chat about the consider. As you guys have seen, with NCCN, we kind of say consider versus recommend, and they're a little different. But there is enough data. That is something, again, I would still say it's an option, but it's an option that I do talk to my patients about, and certainly advise that it is something that they should really think about seriously.
That's really helpful. Thank you so much for sharing that. Well, I think maybe this is a good opportunity then, as we're kind of talking about diagnosis of breast cancer in these ways. One question I had is, what advice do you have, Dr. Park, Harvey, Vicki, what advice do you have for perhaps a man who's been recently diagnosed with breast cancer, or perhaps as well, someone who's recently tested positive for an inherited gene mutation like BRCA2, for example?
I will start. I think any
Please.
patient really who gets a cancer diagnosis, really, I think Vicki said it has to be their own advocate. And even though there are plenty of great oncologists throughout this country, if not the world, we're talking about a really rare type of cancer. And so I would always advocate, even for not so rare cancers, to get a second opinion. Make sure you know what your options are. Talk to other people. I always tell everyone this. If your oncologist is in any way, shape, or offended that you want a second or third opinion, you don't want that person as your oncologist. I, as an oncologist, encourage second and third opinions, and that's what we should be doing. It's all about the patient. And breast cancer, again, is a rare enough disease that, again, we saw, like, is it age 50? Is it 40? It is 40 now for women. You could make the argument could be 50, but again, it's because we just recently changed the guidelines for women. And in many ways, some of the stuff just doesn't fit neat boxes because we don't have that data. So going to an academic medical cancer center that has experience with male breast cancers, just getting at least a second opinion, because there's a lot of things that I've seen that make me kind of think, yeah, that's probably okay, but this is why we do it this way for male breast cancer as opposed to female breast cancer.
That's really helpful. Thank you.
I was going to say, when I was diagnosed, I got put through the ringer quickly, but I very fast learned that the doctor that was going to work with me had to be somebody that had an understanding of what I was going through. I found a breast surgeon who had done one other guy, but that's all I could find in Rochester, New York at the time. And he was fine. I still to this day thank him, but they referred me to a general oncologist who didn't know what was going on. I had HER2 testing that he misread. And that's when I realized that I'm in charge of this, not being put through the system. And actually in our blog site, on our newsletter, on our site, I actually wrote a couple months ago, a blog that said, you can fire your doctor. I mean, people get, there, and I don't want to insult Dr. Park, but if you don't like where it's going and it's not the right person for you, and you think there's any kind of question there, get another opinion, get a third opinion. When they told me I had to have chemotherapy following my surgery, I was shocked, but I actually sought out 4 different oncologists across the states. I traveled, and all 4 of them thought I needed some form of chemotherapy, but there were 3 totally different regimens. And that's when I realized, ultimately, I had to make that decision. And my attending oncologist pushed back at me. She goes, you have a very aggressive form of breast cancer. Don't you want the most, the strongest drugs we can give you? I'm like, none of it's going to give me, lymphoma afterward, because that's what we know some of those drugs do. So I think Dr. Park hit it on the head. You have to have a second opinion. You can't be afraid to go somewhere else. If you had a bad plumber, you wouldn't keep calling them to your house to fix your toilet. You'd get a different plumber. So why would you not try and get a different doctor if it's not going right for you? And that's one of the things we preach every day. Get a second opinion, understand your options, understand everything that's going on, and don't just be pushed through the system, like without a say in the matter, because ultimately you have one life. And if you make the wrong decision and you don't make it, the doctor unfortunately can move on to the next patient. You don't have that option. So you have to be very, very vigorous about how you handle your treatment. And yeah, don't be afraid to ask questions, and always take somebody with you to an appointment, because there's so much information. And I don't know if doctors like this or not, but I always say ask permission, but record the conversation so you can go back to it later. Just the advice we try and give them for that.
I think
Thank you so much. Go ahead, Vicki.
It's hard because, it's often given to you in, well, you can do this and you can do that. You can have lumpectomy, you can have a mastectomy, you can have radiation, you can have, and it's kind of, I'm not the expert here. I'm not the professional. How do I make that decision? Nobody has a crystal ball. The doctors don't have a crystal ball. They are only going by what's based on maybe a 65-year-old adult, and maybe I'm 40 years of age, and, a male versus a female. So there's a lot of different things to take into consideration when you're making those decisions. And of course, the genetics part of it makes it a little easier to make decisions, but it's still, there's still a lot of decisions. I had a 4th breast cancer diagnosis. I thought I did enough after my 3rd. I did radiation. I was on tamoxifen. I went and had the full hysterectomy. So I thought, I'm ahead of the curve here. Not that I didn't think it couldn't return, but I just thought I had, maybe 30 years like my mother would. And when it was barely 10 years later and they thought they saw something, for me, it was not even a question now. I know I have to have a mastectomy. And, there was a small part of me that in the back, and this is not anything scientific or medical, this was strictly, myself and my emotions. My body said, make breast cancer, with genetic mutation. And if I remove the breast, now where do I look for it? Because my body's still going to have a hard time killing off those cancer cells, and it's going to find somewhere else, and I don't know where to look. So there was a little bit of a security blanket in there with, it's not why I kept them at first, but it was there in the back of my mind. And so when I finished my double mastectomy, and now I'm on an aromatase inhibitor, for the next 10 years, and my oncologist looked at me one day and said, I think we need to consider chemotherapy. My oncotype score was a little high, and I wasn't expecting it. All the knowledge that I had and the experience, I wasn't expecting chemo, and I had to wrap my brain around that one too. So, you really, there's a lot of information thrown at you at one time. There's a lot of emotions going on, and, we look to the professionals for guidance. And that's the important word, is guidance. And then you have to do what feels right to you. And what, and yeah, you might look back in 5 years and say, I should have, but nobody really knows that anyway. So it becomes, and I think another important part to answer your question, as somebody that's been recently diagnosed, finding support, finding other men, especially, we'll talk about men here, that have been through this and can help answer some of the questions. And so I think that's a critical part. And I also think taking care of your mental state. You've got a lot of anxiety, a lot of stress now put on you. Can you keep working? How do you provide for your family? What are you physically going to be capable of doing? What are you going to look like afterwards? I think all those things. So, not to negate that mental side of it, and having support there as well.
That's great. Thank you so much, all three of you, for sharing your thoughts on this. I think it's always really helpful, to hear what are, some advice kind of looking back, or, helping patients where they're at in terms of empowering them, your body best, as well as partnering alongside with the clinician, right? So that's really great advice. I appreciate that. I think another.
I just wanted to step
Please.
in again, monitoring the chat. And
thank you.
There are some questions about what are the genes that are associated with breast cancers. One thing I will say is, through the NCCN guidelines, we have, and again, I think Dr. Park wrote it out, National Comprehensive Cancer Network is what it stands for. Those are national guidelines that are considered, what clinicians across the US should be following. It's best practices, essentially. So there are guidelines focused on inherited breast, ovarian, and pancreatic cancer, and anyone can access it. Again, I know people are sometimes leery about having to create a few username and password, but this is a legit site. We all have usernames and password. It's a not-for-profit, so they want to track usage. That's the only reason for it. So they're not selling your data or anything. But I would encourage you, that's another way to stay empowered with the latest information. And again, through ICARE, we have done some links, because it has come to our attention that sometimes it's hard for people to navigate how to get to those guidelines. So please feel free to reach out to us. We've actually got detailed instructions about how to access these guidelines. And I can personally tell you, we do update these guidelines at least once a year, if not more. And I know that we are going to be updating them at least another time, if not yet another time this year. We just released the guidelines, I think it was September 11th or so. But there will be another version that updates, hopefully within the next few weeks. So it's important to continuously monitor. And again, that's why we have tried to be active on social media, just to get the word out. We can't be comprehensive because, again, you have to give the information in little chunks, but we hope that it's helpful in starting a discussion with your providers. And I know both Harvey and Vicki are in great hands with providers, but there are others that may not have physicians that are as knowledgeable or as up on the most recent guidelines. So I think it just takes a village to make sure that, you know, we as the bigger we, so both patients and providers, stay on top of guidelines because things are changing very quickly. And I'll give you an example. With BRCA2, the guidelines that were just released in September, we are now advising that anyone with a BRCA2 mutation, regardless of family history, can have pancreatic cancer screening. That's a big change because before we were saying family history of pancreatic cancer, right? So Vicki and Harvey met the guidelines, but many other BRCA2 carriers did not meet the guidelines. Now anyone with a BRCA2 mutation, same goes for ATM. Anyone with an ATM mutation, regardless of family history, can consider pancreatic cancer screening. So super duper important to stay on top of guidelines.
Absolutely. No, thanks so much for interjecting. And as you can see in the chat too, there's been information given there in terms of how to log in, where to go, and what that looks like. And as Dr. Cragen points out, you can also download the guidelines and take them to your physician if, for example, you have an experience like Harvey kind of explained earlier in terms of not having as much knowledge, perhaps from a physician. So I think another question, I know we're getting close to the end of time, so I want to be conscious of that. But another question, and something that's kind of come up a couple different times, is what would you say to someone who has undergone genetic testing and they have children, right? And encouraging children to get genetic testing or also screening. And Vicki, I know you and Harvey kind of talked a little bit about your experiences with your children, but there's been at least one question in the chat about, you know, what do you say to children? What would you recommend? And so I wanted to give the opportunity both to Dr. Park and to you as well to touch on that one last time.
Do you want to go first, Tua? By the way, I didn't know this was going to everyone, but is Michael Singer your brother, Harvey and Vicki?
He is not. He is not, but I do know him fairly well.
Yeah.
Our community is pretty small. The male breast cancer activist community is pretty small, so we kind of all know each other.
All right.
And sometimes we work together, sometimes we don't. But yeah, I know exactly what you're talking about. Yes, I do.
Now I completely forgot the question. Sorry.
What do you say to your kids? How do you talk to your kids about?
Yeah. So in your consultations with, you know, men who've been diagnosed with breast cancer, what would you recommend, Dr. Park, in terms of like thinking about genetic testing and talking to children about that? And then we'll flip it over.
You know, again, it depends on the age of the children, right? You know, if they're clearly adults already, that becomes probably a little bit easier. And if they're 18 and above, they could even get tested and, you know, go through all the consent. Tua knows way more about that than I do. But I also think it's also an individual thing when, regardless if you have a hereditary form of breast cancer or not, when you have children and you have a diagnosis with cancer, that's a really tough thing. And so I usually recommend resources. We have a lot of great books and knowledge pieces that are available on the internet. We also have child psychiatric and family counseling, which I think is critical and essential when a family member is diagnosed with cancer and they have children, particularly young children. There's also this wonderful organization that I've been a part of since I was at Hopkins. I'm less involved now at Vanderbilt, called Camp Kesem. And this is something that probably a lot of patients know about already, but it started at Stanford. It's a summer camp free for kids whose parents have cancers. And it is really, I think, game changing for the vast majority of those kids. They basically get together. They don't talk about cancer at all in the first couple of days. And really, it's more about being a kid again. And some of these kids have lost their parents to cancer. So you can imagine the trauma that comes with that. But there are resources, is what I'm saying. And I think it's like everything else. You got to sometimes be your own advocate and ask for them or look for them. And if you're not finding the answers that are helping you, then dig deeper, look around, get on the internet and find the help that you need, because it's really important, I think, when you're dealing with kids whose parents have cancer.
Thank you so much. I appreciate that. Vicki, Harvey, any other comments there?
I will say that we do have, you mentioned resources, and on the his breast cancer awareness website, there is a resource page. And it covers pretty much everything from A to Z, whether it's other organizations or support groups or places where you can just gain information. So I would say, check that out, and I'm sure you offer that as well. Like I said, so I think it's out there. I think there are great, and I've seen great books that people have written, people every day, diagnosed with a genetic mutation and have gone ahead and written books for children and how to talk to your child. And, my children were a little older by the time I found out about the, genetic mutation. So even though we had the conversation, they were in college, and they weren't really caring so much about mom and her diagnosis and what she goes more about, what fraternity party they could be at. So, I think it really depends on the ages of your children, the mix, boys, versus girls, et cetera, and as far as screening, it's really, I know it's not recommended, too young. You want them to be old enough to be able to understand the information that they're about to receive. And that's a maturity level, again, that changes by age and maybe even by gender. So, in the film, in the Pink and Blue film, we have a young girl who was one of the youngest to ever, be diagnosed. She lost her mother, and she then got tested and found out she carried a mutation and had a mastectomy at a very young age, so I think it's very individualized, and what's right for you as a family to have that conversation.
So
Thank you.
the only other thing I would add is, like, when I see patients, the thing is, there are pros versus cons of testing, right? If you test too early, it could affect insurability. And I'm not talking health insurance, but things like life insurance, disability insurance, other supplemental types of insurance, which, again, recognizing there are state-specific differences, because certain states are great in terms of having some extra protections in place. But really, what's important is, how is it going to change your management? Like, that's when I push or, really encourage testing. So if a 20-year-old female comes to me and says she wants to be tested for a familial BRCA1 mutation, I'm not saying super early breast cancer in the family, because again, we may tailor the screening based on age at diagnosis, right? So usually we'll say age 25, we start the MRIs, age 30, we start the mammograms. So really, is there a reason to get tested before age 25? The only other thing I can think about that I would consider would be if it would impact their family planning decisions, right? Because we do have technology now to do IVF, fertilize the egg outside of the body. When the embryo grows to the 8th cell stage, test the embryo to see if the embryo harbors the specific mutation or not, to be able to then selectively reimplant. So some people are interested, others are absolutely not interested. And I don't think there's a right answer here, but that's where I'm saying, is it going to change medical management? I think needs to be front of mind. Again, are we going to stop people that feel super strongly about having BRCA testing at age 18? No, we're not. However, we're going to try and explain to them that, hey, what are you going to do with the information? How is this
Mhm.
gonna benefit you? Here are the risks versus other than, knowing if you have it or not. That's the only benefit. We're not going to do anything with it. And maybe the emotional or mental benefit is enough, but it will be a discussion that we would like to have with folks before they move forward with the testing, if they are young and we're not going to do anything in terms of medical management.
Yeah, that's great clarification. Thank you so much, Dr. Pell. Harvey, any other comments that you wanted to make there? I wanted to give you an opportunity there before I start wrapping us up.
Thank you. I think Dr. Powell hit on something that my two children were diverse in their opinions of this. You talk about the positive diagnosis and how's it going to change, but like one of the things I said to my son after he finally got tested was, you could have known you were negative 10 years ago. My kids had the advantage, they were both away at college. They did not see me go through surgery and treatment. We talked every day, of course. I think, Vicki, your kids may have been home, or may have, you were 37, so when you started, so they saw something earlier. But I think it's a dichotomy. Do you get tested early? Do you not? So, did I lose you? Because I just switched over, my screen switched over here. But I think it's just, it's an individual thing, but you have to think about the positive as well as the negative. Honestly, I just went through, I was coming out of a urology checkup a few months ago, and I got stopped by a student, and he said, would you be interested in retesting? I know you're BRCA positive. Would you be interested in retesting? We're doing a study. And at first I thought about it. I said, no, I know what I have. And then I said, you know what? If it helps somebody learn something, and I went back and had another full panel done. And they actually came back with a potential non-germline, but potential, I think it was a PALP. No, it was a check 2, I think. But it wasn't deleterious. Is it deleterious? How do you pronounce that word, right? So the genetic counselor said to me, it's fine. It's just something that showed up. It's not something you have to worry about. But I just think everybody, the more we know, the more we can adapt ourselves. That's that's how I've processed this for the last 15 years, and I'll continue to process it. So I just think education is such a key to understanding how to go about your life day to day.
Absolutely. No, thank you so much for sharing that. And, I think that also demonstrates another aspect of, which I think is a common theme tonight, being your own advocate, empowering yourself and learning, information. And that is, you can also be a part of research studies, right? So that we can move things forward and try to improve health outcomes for us, right? So thank you for that. All right. Well,
Just one other
ahead.
wanted to highlight, there's certain things where I don't think it's really a choice. Like if you have a woman with a BRCA mutation, you can't just sit on it. Like at age 25, screening needs to start. So like when we're saying recommend, and I kind of touched on this before, versus consider, like, again, there are some subtle differences. One in my mind is not a choice. Like I will push, and even for BRCA mutation carriers, and having the ovaries and fallopian tubes removed. That again, to me, I push for it. Like I know in the past we had quote unquote non-directive sort of counseling. To me, that is not like an area where we should be non-directive, right? Because we don't have any other options when it comes to ovarian cancer early detection. All we have right now is removal of the ovaries and the fallopian tubes. And we also know that that saves lives. So again, I think there are subtleties. Some things I think are options. We owe it to our patients to be able to educate them to make choices that are right for them. But we also should be pushing for things we know to be right. And again, like Ben could speak further on this, but in the treatment realm, I don't think BRCA testing in certain scenarios is a choice anymore, because that's going to guide your treatment, right? So that's not the same. Yes, we still should be telling people, hey, here's what your risks are, because it's not, if you're a breast cancer patient, you're still at risk for ovarian cancer patient. And I think we have all seen this in our practices, and it is depressing where someone survives breast cancer only to get ovarian cancer because their doctor didn't mention it to them or they didn't get tested, right? So that's
Mhm.
where I do think educating our patients is really, really important. But giving them choices where choices exist. Like I said before, this is like for testing in young adults or children. I told you what my approach is, but at the end of the day, if a young adult or an 18-year-old feels strongly because of family circumstances that they want testing at age 18, am I going to withhold it? No, I'm not. However, I'm going to try and talk them out of it and tell them reasons why they might want to reconsider. But I think there is a fine line between certain things are a choice, other things, if you have this information, we as healthcare providers feel pretty strongly there's a certain way forward.
Yeah, thank you so much. I appreciate that. All right. Well, as we wrap up tonight, I wanted to ask one final question. So think of this as your soapbox, so to speak, for a second. So, Dr. Park, I wanted to give you the opportunity, any final closing thoughts as we think about men and breast cancer, any new innovations, any exciting things coming down the pipeline, or any closing thoughts here?
Well, I kind of mentioned it. I think that an area of research interest of mine that Tua had mentioned is really looking at these liquid biopsies and cell-free or circulating tumor DNA. I really think this has the potential to really change practice in how we screen for cancers, including breast cancers, and how we treat them for early stage disease. I envision a day where we're not going to treat everyone with everything simply because they're at the highest risk, or we're not going to treat lower risk patients with minimal stuff because they're at low risk. We will actually define risk based upon liquid biopsies. And then similarly in the metastatic setting, we'll be able to really figure out whether drugs are actually working. You can almost think of this as a glucose monitor where you stick your finger, but after a given therapy, we'll be able to tell whether or not something's working almost in real time rather than waiting for a scan 2 or 3 months down the line. So that's the future for me. We've got a lot of great drugs that didn't exist 20 years ago when I first started in this business, over 20 years ago. And so there's real, I think, opportunities, enthusiasm, and optimism in terms of the future.
Yeah, that's wonderful. And as a patient myself, wouldn't it be great not having to wait so long to hear back about answers for tests? So that's
Yes,
wonderful.
exactly.
Thank you for all you're doing in the research realm and in clinical care.
Thank you.
Harvey, Vicki, last thoughts, final closing. Here's your soapbox. You get a couple minutes here.
All right, I'll go first, Vic. I think knowing your body and knowing the changes of your body are so important. Something Vicki touched on real quickly, but she didn't really elaborate, is staying in shape, staying exercise, even if you're a carrier. When I went through chemo, my doctor didn't give me any help. I stayed with some supplements, but I exercised. I got up. I forced myself to work out every day. And at the end of it, she said, "You handled this amazingly well. You handled the chemo. You didn't get as sick. You aren't run down from it." So I think just keeping your general health while you're going through cancer treatment is important. I don't think we touch on it enough. I'm probably in the best fighting weight shape I've been in my whole life now because I worry about everything and I take care of it. I know Vicki's been like that for years. She's been my coach in a lot of this stuff, eating healthfully. So you can have the genetics. You can't fight some of those genetics, but you can fight some of the environmental aspects of it. And staying in shape going through this, I think, is extremely important. I don't think we focus on it enough. So that'll be my soapbox part of it.
Thank you so much. Vicki?
I think that, more and more we know that young women are being diagnosed with breast cancer. And so I don't think we should exclude the fact that young men and, have that risk as well. Most male breast cancer is hormonally driven. Men do have hormones. I want to put that out there as a little flag and a reminder, so often breast cancers are estrogen, progesterone based. And, the foods we eat, some of the things that we do, are surrounded by a lot of synthetic and plumped up, that chicken that's really juicy and big. Well, there's a reason it's extra big. So, I'm a proponent of choosing organic foods when I can. and more plant-based diet. Doesn't mean, like Harvey said, that I'll never be diagnosed with cancer, but it just, at least I feel like it's giving me some control, something that I can do.
Mhm.
And I think that's a good feeling internally. So I think, yeah, taking charge of your own health, being aware and making good choices. And our website, we do have a section for young adults. So I want to mention that on my soapbox. We have blogs, we have guest blog writers, so we always welcome sharing other stories of what other men have gone through. And, we're here for you. We're here for the men. And so please don't hesitate to reach out or follow us on social media or join our support group. And yeah, Harvey and I aren't going anywhere. So yeah, we're here to help.
Well, thank you. Thank you so much for turning your cancer experiences into something that is increasing awareness and empowering others. And thank you for all that you're doing for men in this space and women too, of course. So that concludes our patient forum tonight. We want to thank you again for joining us about inherited breast cancers in men. We wanted to note that this is recorded and this will be shared, so you'll have access to this again and again in the chat. We've tried to answer a lot of those questions, but you can always reach out to, as Vicki and Harvey said, in terms of his breast cancer awareness and ICARE as well. Thank you again, ICARE, for hosting this. So thank you to our panelists. We appreciate your time, and we hope you all have a good night.
Thanks, everyone.
Thank you.
Thank you. Goodbye.